officially welcome you to May's Orem Aide training. You guys, thank you for coming. Also, when you leave, there cannot be any food left up front. The drinks, yeah, we'll put those in the fridge. But if there's bagels or anything left over from McDonald's, please stick it in your pocket, take it out of here, okay? Reviewing the quiz quickly, what is my favorite Jamba Juice flavor? Do you guys know what that is?
Strawberry sherbet.
Not strawberry sherbet. I don't even think they have that.
It's surf something else.
Oh, so did anybody say raspberry?
That's the only one I know.
No? Well, put that on there because I have been giving some pretty free passes on the Jamba infractions over the last couple of weeks, so those are coming to an end. I'm going to start enforcing the Jamba rule. And I expect you to follow Eric's example, and he is not letting me off the hook ever. He gets me off on the timers especially. So if you want a hint on how to get a Jamba Juice out of Steve, if you see me running to get an ice pack for a patient to set them up, ask me a completely distracting question about something different. And I will put the ice pack on the patient, forget about a timer, and then you can, that's devious, but it's also worth a Jamba Juice. Oh, here's a copy of the quiz that we are going over right now. Hurry, fill out, we're on question number 2. Well, yeah, why does it matter that you know the favorite Jamba Juice flavor of mine? Because you may have to get it. 4. Which should be completed first while doing patient notes? The daily notes on therapy control or the supervital? Anybody? Daily notes, yeah, do that first. Which direction do you point the electrode leads? Would you throw me a pair of electrode leads, please, out of the drawer? If I am setting up some electrode leads on a patient, and let's say their body part is here, and the machine and the wires are over here, which direction do these little leads go?
Doesn't matter.
Towards the
It
machine.
does.
It does?
It matters because you want the electrode lead to, if there's any tension on the wire, you want it pulling directly off the pad this direction instead of this way, because this is how it ruins the electrode, okay? So wherever they are, wherever the wires are coming from, that's where you want these leads pointing. That just helps preserve the life of the electrode. How do you place pillows under the leg when doing a knee or ankle setup with elevation? I heard it. I heard somebody mumble it. Say it with confidence.
Long ways.
Long ways, yes. So if I tell you, or Karen tells you to put 3 or 4 pillows underneath their leg, if you put the pillows under their leg like this, it's not a Jamba infraction, but it's becoming one. They need to be put this way, lengthwise. So you're elevating the leg and the ankle instead of just kind of keeping the knee higher and letting the ankle drop. Okay? Name 2 things that are enhanced or facilitated for a patient when you have them set up properly. What's one thing that a patient experiences when they're set up properly?
Comfort.
Comfortable, okay? And if they're comfortable, what are their muscles going to be able to do?
Relax.
Relax, okay. So if they're not really comfortable and they're not relaxed, then it doesn't allow that treatment to be as efficacious. Ooh. Yeah, you can write that word down. Triple word score today. Okay. Now back to electrodes. When you pull them off of a patient, this is when you pull the electrodes off a patient, or the electrode plastic protector sheet. Which part of the electrode do you pull from?
The top.
So saying the top, are you talking this, or is this the top and this the bottom?
Away from where the line comes.
Okay, so are you lifting the electrode itself, or are you pulling from the wire?
Not the wire.
Never the wire.
Never the wire. No.
Never, ever,
the wire.
ever.
Wire's bad. Bad. Body of electrode good. Wire of electrode bad. Okay, you guys are good. I have no doubt that you have that. Electrode care. How often should the electrodes be cleaned?
Every use.
Between every use, yes. Do you ever make the subjective call, you know what, I think that patient's pretty clean. We're gonna be okay this time.
Never.
No! Those little viruses are so small you can't see them. I've listened to Dr. Fauci enough to know that. And who is responsible for throwing away damaged or overused electrodes?
Anyone?
Anyone. If you see an electrode that looks like it, if it's marginal and you, well, now here's one. What should I do with this one? You see what's happening here between the fabric and the electrode itself?
Falling apart.
Not good. The reason this is not good is because the electrical current is actually distributed through this fabric and then transferred to the patient through the gel. If there is a gap between the fabric and the gel, that electrode can arc. And do you know what an arc is? You ever seen a spark jump from one electrical item to another, like a battery terminal? That's an arc. And arcs are painful. They can cause blisters and burns and stuff like that. So a damaged or falling apart electrode is dangerous to use on a patient from the standpoint that it can give a burn or a blister.
Hey Steve, how much separation, like any kind of separation at all?
More
is
than
it
a
done?
quarter inch.
Okay.
So this one's like a half an inch, so it'll be thrown away. But a quarter inch is the distance that you need to just say, yeah, that's got to go. So true, false. Every elbow setup, heat, ice, electrical stim, should be on a pillow for patient positioning and comfort. That is one of the very few true-false questions where the word every works. You don't want to just set them up on the table. You want a pillow underneath there because it allows for the heat pack to have better contact underneath as well as on top. Now, one thing I wanted to cover with you guys is when you are putting a heat pack on a patient, after you've placed the electrodes on them, I want you to start getting in the habit and then sharing this with our comrades. Put the electrodes on, then put the towels on, make sure they're firm around the electrodes, and then put the heat pack on. So even though you're building the heat pack with towels and stuff over here, you put the electrodes on the patient, and we're often, you know, like, it's like we're flipping over a flapjack over the top of this patient. Just take the towels off and place those over, because we don't know, and often it happens, we can't tell when the electrode is kind of folded off or peeling off of the patient, and we're trying to time it so that everything lands on top and it cooks right. Yes, Spencer?
Are you still talking about an elbow setup or any setup?
Any setup, yeah. Anytime you're using heat with electrical stim, yes.
If they're just laying on top of it, do we just do it how we have been?
Yeah, if you're putting it on the table and having the patient lie down on it, then we are in that instance still trying to make sure we get them to lie down just right. But when you have the opportunity, yes, Todd.
Something that helps with that is like if they're kind of like peeling off a little bit, if you like hold them on as they're like laying down, like a lot of times with the neck at least, they fall off really easily unless you hold it.
Yeah.
And, like once the pressure is there.
And on the neck, you can actually bring the hot pack up to the patient and hold that on there as they lie back down so you make sure the place is right. Because I know I've done this in the past where I'll put the cervical heat pack on the table and the large heat pack. They're sitting where I think they're going to lie down on it right, and it may be perfect. You say, man, you landed on that right, just awesome. Or maybe they land on it and the heat pack's like right up here at the crown of their head. You're like, it's close enough. No. But if you hold the heat pack up against their neck and help them lie down, then that's good. Excellent points.
Steve, I have a question.
Yes, ma'am.
If you're working on someone's back, should you always put the wedge underneath their legs?
If they're lying on their back, on the heat pack, yes. Always always give them a wedge. That's important. And that takes pressure off the low back, which is why that's helpful. True, false. I love my job here at Rock Mental Health, Sports Medicine, Physical Therapy. I already
Truest thing in
know.
the world.
I already know. It's the best job you've ever had. Essay. What is the most important question to ask a patient when you are first getting the subjective report from them? There's one question. It can be worded a little bit different by everybody, but the basic question is, does anyone remember it?
How's your physical therapy going?
Exactly. How do you feel you are progressing with your physical therapy? That's the most important concept question that you can ask when you're asking a patient their subjective. We often ask people, so how are you doing? And the most frequent answer is the polite, I'm doing good. And that's not what we're writing down in the subjective. We really want to dig in and drill right down to the meat of the question. And when you ask it that way, their brain picks what you need to hear and what they want us to know, and they'll share it with you. And some patients are really good sharers, and some are not. So you have to kind of get a little bit more into it with them, ask them a couple more questions to get information for us.
I should have a follow-up question.
Uh-huh.
Sometimes when people are really good at giving you information, there's only just like a limited spot for us to write the subjective. How do you like filter through that? What things should we be listening for? Like this is the most important stuff we have to write down.
Very good question. So what she's asking is, and you guys all heard that, patients may volunteer a ton of information. What do you decide is the most important information to write down in a small spot? Because we do want that subjective to be grammatically and, punctually correct, punctuationally. Would that be the word?
Sure.
Okay. We don't want it to look like, I'm going to jump forward a little bit. Every one of these notes goes to an insurance company, and the insurance company has somebody who's got at least a GED reading it. And I want notes with my signature attached to them to be at least at the level of education of the person who's reading it at the insurance company. So GED level quality is what I'm looking for, or higher. Higher than second grade at least. In answer to that question, what do we decide is the most important to put in there? It would be the concepts that have to do with pain, concepts that have to do with mobility, concepts that have to do with tolerance to their activities of choice, like maybe it's a runner and they haven't been able to run, maybe it's a homemaker who hasn't been able to clean the house, maybe it's somebody who works who hasn't been able to go to work or can't sit, can't stand, functional things, pain things, mobility things. And then the extraneous you can filter out around those points. Is there anything else that you think would be, yes?
What are the things you want us to avoid?
I want you to avoid writing things in the subjective about their most recent vacation, or what their favorite color is, or why they don't have a cat, or why they do have a cat, or dog.
Sometimes they share about like medications, like if they started a steroid pack or something. Do you want that in there?
If it has something to do with medication, a really good thing that you can put in the subjective is patient has questions about medication we'll discuss with PT.
Okay.
And then we will then put that in our assessment and plan side of the note. Okay? So you can reference the idea and then make sure we're aware of it so we follow up with that on the portion of the note that we take care of. Okay? Yes, Alexis and then Jay.
How often do you want us addressing body parts in the subjective that is not what we're actually treating?
Never.
Ever. That's
Well,
always hard
I
to
shouldn't
ask.
say never, that's not true. You need to make sure that you're focusing on the body part that we are treating on the diagnosis. So I think the never applies to this. Never put other body parts and not the one we're treating in the subjective. Like if somebody comes in with a right shoulder surgery and everything in the subjective has to do with their ankle sprain, that's not good. We need to have, you can say something about their ankle sprain, but we have to be saying something about the treatment area that is on the diagnosis on the top of the page. Does that help?
Mm-hmm.
Okay. So you can reference it if there's room. But I know that me as a therapist and Karen, if we're treating other body parts, we often indicate that in the assessment and plan portion of the note.
And what about concerns they have about their progression?
If they have concerns about the progression, I do want that in the subjective.
Okay.
Like, patient is concerned about their lack of progress. Absolutely, that needs to go in the subjective. Okay, these documents are legal documents, And so the information that the patient is giving us relative to their injury that we're treating, we need to represent that in the note, and it has to be accurate like that. So good question. Okay. Any other questions on this? Okay. All right. I do have some quick little housekeeping stuff that I want to go over with you guys. Some of this is going to be a little redundant, but as soon as I'm done with that, the star of the show, Camille, has a presentation that she's going to give us today. So it's going to take about 15 minutes, so I'm going to take the next 7.5 to get through this. Good? All right. We talked about electrodes, so I can check that off. Make sure that when a patient when you're taking the heat packs off of a patient, don't leave them in the room while you're doing the rest of the room treatment. Some of you, and it may not be anybody here, but we do have some staff that have been leaving heat packs in a room for that next 15 or 20 minutes before they come back out here with the heat packs. And we need to make sure they get into the heat pack machines as soon as they're off the patient. Plugging in and unplugging of the ultrasound heads. Now, because the Dynatron machines have these 10-pin plugs, the reason we started unplugging the ultrasound is because we learned in Lehigh with their equipment that as soon as the power is on the machine, there is power running through the ultrasound head, and it actually has burned out the crystals on some of those machines. So we, in my brainiac idea, if I'm hooking somebody up to electrical stem on a combo unit, the ultrasound's not being used, there's 10 minutes of electricity running through that head that could burn it. And I thought, well, if we unplug the ultrasound head, all things are good. Unfortunately, not everybody who unplugs and plugs in an ultrasound head is a civil or a mechanical engineer. And so we've had people plugging and unplugging those ultrasound heads in like, just get that, it's gonna get in there eventually. And those pins are very fragile. So you've got to be very careful while you're pulling out and pushing in the plug on the ultrasound heads. Always grabbing the plug, not the wire, okay? And that way those $450 ultrasound heads won't break as often. So that's that. HIPAA compliance and discussing patients' information in and out of the therapist's office. Every exercise sheet that we're walking around here with has patient information, including their name, social security number, phone number, their diagnosis. It's private information that we have the responsibility of protecting for that patient. So, first off, when you've got a subjective and you're coming to tell one of the therapists what that subjective is, if we're in and around other people, then don't say the name of the person. You can say everything you want about him. You say, I have so-and-so here. They have a problem wiping their butt. You can say all kinds of terrible stuff. Don't say their name. But if you say, John over there, don't go too near him because, you don't want to do that. So no name, just hold the sheet, let us read the name, give us their subjective. Okay, that protects whoever it is you're talking about from the person that's around that can hear what we're saying. Now, if you come into our office and we're sitting at our desk doing notes, and maybe I'm talking to somebody and you're one of 3 or 4 people in line to ask me questions, that's okay to say, you know what, Alice is here and this is what she said. In that room, that's fine. But not out here, not around other people, okay? We've got to be very careful with that. In conjunction with that, we have to protect the location of where we keep that paper. So leaving the paper here while you're showing a person how to do a 3D lunge, not going to work. Leaving the exercise sheet here while you're going through body blade, not going to work. Leaving that here while you're setting up on the Jenny bender, that's not going to work. Because whether there are or not other patients in the office, I need you guys to get in the habit of you're either holding this, or you're putting it back up there, or you're putting it in one of the rooms where the patient came from. Not lying around in the office generally, because we just can't have people I know we don't typically have patients that would be interested in that information, but we can't put it in a position where they could get it if they were, okay? So that we need to protect.
Is it sufficient if we turn the paper upside down?
I just would prefer that you put it in one of the places designated. Then we're gonna be, I mean, I understand what you're saying, but I'd rather get in more of a consistent habit of putting it in the right place, okay? When doing patient documentation, always make sure that you are entering the subjective as soon as you get it, and using, like I said, correct grammar and sentence structure. Also make sure you're entering the exercises that the patient is doing while they're doing them, or make sure you're getting it entered as soon as they're done, okay? So that we're not, as we're doing notes later on in the day, like, oh my gosh, did so-and-so do whatever, and that aide's gone, we don't know. We have new aide training modules. You guys are gonna be, you finalized most of that, including the quizzes. What I'm telling you basically is, instead, how many were there before?
There was
Quizzes?
like 12.
How many modules?
12.
Oh yeah, like 12
There's 12.
or more.
12 or more.
Yeah.
12 or more. Well, there's less. There's now 8,
Yeah.
right? And there will be a quiz at the end of, there's 4 quizzes,
Yeah. So after every couple of modules, there's a
roughly.
quiz.
Like one quiz for every 2 modules.
Yeah.
And there will also be 4 practicals, okay? Everybody needs to start over. Everybody needs to go through that. What you've noticed as you've gone through some of the other modules is there's stuff in there that you don't even know what it means. Diathermy? What? We're taking people's elbows to the microwave? We're not doing that yet. So we're all starting the modules over, and all the quizzes, all that kind of stuff. And then my last item, man, I'm at 7.5 minutes. You guys notice this bulletin board with different things on it. The top says time. I want you guys to really be paying attention to that. What we used to have on the back of our aid shirts, time, T-I-M-E, for teach, inspire, motivate, encourage. We want to make sure that we are all, and you guys, actually, you've done a fantastic job of that. But always make sure that you're paying attention to that when you're putting on that shirt and working with the patients, that they are here, the patients are here, they want to learn. Many of them are a little bit down or frustrated by something, so we are trying to inspire and motivate and encourage through all that we do. And I have to tell you that I get a ton, I mean, you guys don't know this, but I get a ton of compliments from the staff that we have. So our patients love working with you guys, they appreciate the efforts that you put in, and thank you very much for all of that. That is all I have for this morning, so I'm just going to turn the time over to Camille. She's going to talk to us about something amazing. I use electricity. It'll be fun.
Okay, so I'm gonna pass this paper around, and if you guys could just sign your name under the attendee signatures, and then once it gets passed around, if you could get it back to Steve.
Here, you can put it on this clipboard.
Okay. Okay, yeah, just make sure it gets back to Steve, because he has to fill out some other parts. And then, Todd, could I have you bring that card up here, please? Okay, so if any of you guys don't know, I'm Camille and I'm a PTA student. I've just been doing a clinical here for the past 3 weeks, and as part of that, I get to give you guys an in-service. So I'm just going to talk to you a little bit about eSIM, and I'm just going to start out with talking about a few of the most common ones that you guys use here. So first is IFC, or interferential current. This one is mainly used for pain relief. It also can stimulate the muscle and increase blood flow. This one is delivered through 2 sets of electrodes. So there's 4 total that you use for it. And then it also goes through 2 separate channels. And they intersect in the middle. For pre-mod, this one is similar to IFC, but this one only uses 2 pads total and it goes through 1 channel. It's used for pretty much the same things as IFC, mainly pain relief, but also muscle stimulation and blood flow. And then the last one I was going to mention is Russian or biphasic. These two are very similar, so I just grouped them into one category. But the goal of this one is to get a muscle contraction to strengthen the muscle, because a lot of times after people have surgery or get an injury or something, their muscles aren't strong and they can't really generate that forceful contraction. So this just helps them to improve the contraction of that muscle. And this one can be 2 or 4 pads, just depending on the area that you're putting it on. And then I also wanted to mention some contraindications and precautions for e-stim. So the number one that we've gone over in my class is if somebody has a cardiac pacemaker, you don't want to use e-stim on them. Another one is if you have a female patient and she's pregnant, you don't want to put pads on her belly. Also, if somebody has a skin irritation or an open wound or something, you don't want to put the pad right over that. If somebody has impaired sensation and they have a hard time feeling things in a certain area, they're not going to be able to tell you like how high they want the intensity, and it could cause some problems.
You know, can I bring up something really quick?
Yeah.
So we have a patient that we're working with right now. Any of you worked with John Bone? So he does have peripheral neuropathy in his legs, and occasionally we'll have patients who have that. So the point that she's bringing up, there are contraindications and there are concern categories. The peripheral neuropathy would be in the concern category, so you can still use electrical stimulation, but you have to make sure that you're very, very cautious and careful, not just asking the patient for their verbal feedback of what they are perceiving, but you want to be looking at the tissue as well, because you may actually see muscle activity starting to take place and the patient may not feel it. So if you're seeing any motoric reaction in the tissue and they're not saying anything, well, you stop there. You don't go any higher than that. And just say, you know what, we'll just leave this here. Of course, you're using extra towels because you don't want them to get burned because their sensation is impaired, but you can still use it. It's just the observation level and the direct focus on the patient tissue response is much higher and more specific than just patient report.
In that case, should you wait to put the heat pack on them until after you've set them up?
Exactly.
Okay.
Mm-hmm.
We have another patient with diabetes who has peripheral neuropathy in his legs, and would you want to change what you say? Like, tell me as soon as you feel anything, or okay. Yeah.
So your their verbal response and your visual awareness are going to be combined to determine how high you're going to take the intensity. Now, and I'm not trying to take over, obviously, but what I do want to say is that these electrical modalities that are used in clinical settings have a intensity governor built into the circuitry. So the electrodes and the wires are giving the machine feedback as well as what the patient is telling us. And you've noticed that there are certain machines, like you'll be setting it and turning it up and they'll be like, oh yeah, you can keep going higher, and all of a sudden it starts beeping and it won't go any higher, and sometimes it resets itself lower. That's the built-in circuitry that's there designed to protect the patient from what they can't feel as well. So overall we're safe, but we still want to make sure that we're being very cautious and focused on the patient.
So oftentimes we get the tough guys who the machine's going and their elbow is like crunching up. Do we want to stop once we see that motor for even the tough guys?
It depends on what type of e-stim you're doing. Because if you're doing like pre-mod or IFC, you don't want that strong of a muscle contraction.
Correct.
So that's more for like biphasic or Russian. So.
I can think of a specific patient who does that. He goes all the way to max every time. He's like, I'm like, oh my gosh. Dude, how do you like tell him like we don't want that?
You could just say we don't want that.
I'm sure everyone knows what I'm talking about.
Yeah. Yeah, there are those people.
Okay.
Oh, and then one last thing was over malignant tissue. So if somebody has like cancer in a certain area, you don't want to put the pads over that area. And then also, as part of my presentation, I needed to include research. So I just found a study that compares the effectiveness of TENS and IFC in patients with non-specific chronic low back pain. So if you don't know what TENS is, it's very similar to IFC or Fremont. It's just Easton that's used for pain relief. So, and then the non-specific part of non-specific chronic low back pain just means that they don't have a specific cause that's known for that. So, like I said, the purpose was to compare the effectiveness of TENS and IFC. And they included 30 patients between the ages of 18 to 60 who had that chronic low back pain. And they made sure not to include anybody who was pregnant, had a surgery on the spine within 6 months, if they had any contraindications to Easton, and if they had psychiatric disorders. So these 30 people were divided into 2 groups of 15. One group got the IFC with heat, and the other group got TENS with heat. They were all assessed before and after the treatment using a VAS scale, which is just asking them to rate their pain from 0 to 10. And then they also used an ODI scale, which is a questionnaire that the patients would fill out, and it just gave them a percentage of their disability. So the average pain rating before treatment for the TENS group was about a 6, and then after was about a 4. And then for the IFC group, before the treatment was about a 5, and then after was a 3. And then the average disability percentage before treatment for the TENS group was about 42%, and then after was 18%. And then for the IFC group, the disability percentage before treatment was 38%, and then after was 21. So it showed that both of them decreased the patient's pain and their disability percentage. So the results were that there was no significant difference between the two. Both TENS and IFC were effective to reduce the patient's pain and their disability. So I just thought that was interesting because there's quite a few types of Easton that are used to relieve pain. So I was just wondering if any of them were more effective than the other, but this just showed that they're pretty much the same. So yeah, that's pretty much all I had, but was there any questions?
Did the study talk about other functions besides pain that the TENS and IFC did differently?
Yeah, just like reducing pain and then their amount of disability in their ADLs, just like I was talking about with that questionnaire they filled out. Yeah.
What's the therapeutic differences between keeping it on static, on sweep, and on target mode on the STEM machine?
So sweep, I believe it kind of switches off between the pads, and target, they just all go at the same time. Is that right?
They do.
Okay.
And there's a couple of machines that have a target pad. The target pad, like often we're trying to set up the pads so that they bracket the area of discomfort, but because electrical pad and patient tissue hydration are a little bit different and electroconductivity may be different from one pad to another, as soon as you turn it on, it may feel like it's not targeting the area that they would like. So the cool thing about target on that machine is that you can, if you set it on target and then you put your finger in the middle of this pad, these corners of this square represent the pads for the IFC that you've set up. So if you put your finger on here and then move it to the different corners, you can move the intensity on them to where they feel like it's at the right spot. So you set target, you put your finger here and say, okay, I'm gonna move my finger. I want you to tell me when it gets to where it feels like it should be the right place, and it will move the intensity in that field to where they feel it to be most effective for them. So that's how target works. And sweep basically goes back and forth across that field, and scan goes in a circle around that field. That's how those work. but not all machines have the target. So if they have scan and sweep, just know that if there were a field there, that's what's happening with sweep, and that's what's happening with scan, like a radar kind of a thing.
What do you want us to put the patient on?
I don't want. I'd prefer that you turn off target, sweep, and scan, so that we're not trying to get too specific and just be placing the pads. But if you feel like you want to try that, I'd rather you try it on aids on each other first and understand what it feels like, and then if you're putting a machine on somebody, and like say Karen or I are asking you to get the medial, like the Pezan serine tendon, and you've got pads on the medial joint line, then you can say to the patient, you know what, this feature, we can actually try to target it a little bit more to where your discomfort is. Do you want to try it? And then we're like, oh yeah, sure, let's try it. And if you've practiced it on somebody else, then go ahead and do it, and I'm okay with that. But if you haven't, I'd prefer that you're not using those settings. I personally don't like to put scan or sweep on, because when you set the intensity is set wherever the pad intensity is currently in that sweep or that scan. And it may be on a low sensitive area while you're getting max setting. And then when you walk away, it might scan to an area that's really super sensitive, and all of a sudden it feels too strong. So it's like trying to shoot an arrow at a moving target, So take the scan and the sweep off, set your intensity, and then if you want to play around with scan and sweep, you can. Does that make sense?
Mm-hmm.
That arrow target metaphor is pretty helpful, right?
It's pretty good.
Yeah.
Gotta admit.
Thank you. I was looking for that validation. It's awesome.
We try, Steve, just for you.
I accept.
How much of a difference does it make if a patient is on 1 versus 12 for their healing on the settings?
For like the intensity?
With like the pre-mod and IFCs, the pain ones.
It just is to where they're comfortable, really. It doesn't really matter where the intensity is for that. Yeah.
That's true. It really, because one person on pre-mod may go up to 38, and the person right next to him may only go up to 12, and it doesn't mean that one's getting better treatment than another. It's just their sensitivity, and like I said, electropad conductivity and hydration of the tissue. There's a lot of, where the inflammation's greatest. There's so many factors that go into that. Patient comfort's the most important aspect.
You know how sometimes patients will ask that, they're like, well, does that mean like I need to go higher? The higher the number, the better. How do you explain that in simple words to them? That like it doesn't matter.
I would just say that everybody's different, and some people are more sensitive than others. So if they are at a lower setting than somebody else, they might just be more sensitive. And yeah, that's kind of how I would go about it.
Yeah. You can just tell them it really, the intensity is more for, like, we'll leave the machine. If you want to turn it up, you can. I will also tell them it doesn't make it more effective, but if you want it to feel stronger, you can. And that's just, personal.
Any other questions?
Okay.
Thank you.
Thank you very much, Camille. Appreciate it. Love that. Okay, just really quickly, thank you very much again, everybody, for coming today. And then I think Susan has talked to you about how we are not open on Memorial Day, but Tuesday is a Monday schedule. For those of you that are on Tuesday, we are 7:30 in the morning till 5:30 at night. It's like so if you have any questions, that would be it. But otherwise, thank you for coming. Oh, you have a question?
I have so many questions,
You
Steve.
can ask anything you'd like.
So we're all restarting over again on the modules, right?
Mhm.
Who can do the practicals and test those?
Jade, Sadie, and Sam.
Awesome.
Well, and of course, Karen can, but don't ask me because I got to go through them all myself. So, okay, no food needs to stay here. Seriously, first come, first serve. Get it out of my house.